on to the last part of this developmental series. A 12-month-old child has not begun to walk independently. What is the most appropriate developmental milestone assessment tool to utilize in this case? So here, there is a 12-month-old child who's not begun to walk. So by 1 year, we expect that the child should walk with one hand held at least. Independent walking without supports begins by only 15 months, but by at least 1 year, walking with one hand support should be there. So they are worried whether the child is having any developmental delay or not. So what do you want here? You want a developmental screening test to see whether the child is growing developmentally normally, or do we need to intervene here, or can we wait? So what is the developmental screening test? So the developmental screening test which you usually use for this initial assessment is Denver Developmental Screening Tool. Okay, so a little bit important points about each of these developmental screenings. So Denver Developmental Screening Test is usually implemented in children between the age group of 0 to 6 years. And this is a directly administered test. The developmental therapist directly administer the test. So it is a directly administered one. And the time it takes is just 10 to 20 minutes. Then you have something known as the ages and square test, which is also given in one of the options. This is done for children between 1 year to 66, usually done after 1 year of age. That is after 1 year till 66 months of age, you can do this. Not 66 years, sorry. It is 66 months. Here, what you're using is the parent's report. It's a questionnaire which the parents are answering. So it is not a directly administered. This is basically parent report based. So this is parent report based. And this will take around 10 to 15 minutes. And this is validated in India and has got a good specificity as well. Now, a few other tests that you just have to know the names is, one is Bailey Infant Neuro Development Screen, that is BINDS. This is another developmental assessment tool, but this one is mainly used for children between the age group of 3 to 24 months. It is also directly administered, like Denver. This can also be used as a primary screening tool. Then you have another one, that is Parents Evaluation of Development Status. This one is done for children between the age group of 0 to 8 years. Here it is like ages and stages square, that is here questionnaire, that is here we are using the parents questionnaire or parents report. And this one is validated in India and has got a good specificity as well. So these are the few names of the developmental screening tools which are used for assessing whether the child is having a developmental delay or not. This is screening test. Then we have confirmatory test as well. If the child is positive in the screening test, the child should be referred to an expert for the confirmation of the diagnosis. Okay. Now, next one is, we have finished our important questions in development. Now we'll move on to some of the important questions in our neurology part, CNS part. So, a 4-year-old girl presents with inability to jump. By 4 years, the child should start jumping. But here the child is not able to jump and there is poor coordination. The developmental history indicates she was born preterm at 28 weeks of gestation. So, what is the most likely diagnosis? So here we have a preterm child with delay in attaining gross motor milestones are more affected, that is inability to jump, and there is poor coordination. So premature baby with developmental delay, the first and the most important child diagnosis that you have to think is cerebral palsy. Is it an autistic spectrum disorder? Never, because in autistic spectrum disorder, it is not the language, it's not the motor milestones that is affected. It mainly affects language and social domains and cognition are affected. Motor part will be normal. So inability to jump is not consistent with autistic spectrum disorder. Developmental coordination disorder, no. That also there will not be an inability to jumping might not be present. Prematurity is not any way relatable to this developmental coordination disorder. Intellectual disability is basically a terminology we use when there is developmental delay in a child of more than 5 years duration. In a child who is less than 5 years, we cannot make a diagnosis of intellectual disability. Okay. So, what is cerebral palsy? Basically, cerebral palsy, you all know, these are basically disorders. It's a permanent disorders of movement and posture, okay, which happens because of a non-progressive injury to the growing brain. So I'll break it down to you. So when the brain is growing, so the brain grows maximum from the intrauterine life to the first 2 years of life. So during this growing period of brain, any injury which has happened onto the brain, it's a permanent, non-progressive static injury. And that injury can result in certain disabilities. And that mainly involves disabilities of posture and movement. That is known as cerebral palsy. Okay, so the cerebral palsy, we can classify it into different types based on its physiology and based on its topography. Physiology means what is the type of the defect, whether it is spasticity, whether it is hypotonia, whether it is dyskinesia, etc. So, it can be spastic cerebral palsy, where if there is predominant spasticity and hypertonia, or it can be dyskinetic CP, where there is extrapyramidal symptoms are more. It can be atonic CP if the tone is on the lower side, and if there's a mixture of any of these, it can be a mixed CP as well. Then topographically, we can classify it into which part of the limbs are affected. Monoplegia means only one limb is affected. Quadriplegia means all four limbs plus lower cranial nerves plus trunk and neck muscles. All these are affected. It is quadriplegic CP, which is the most severe form of cerebral palsy. Diplegic CP means only two limbs are affected, usually the lower limbs. The spastic diplegic CP mainly involves two limbs, and it is usually the two lower limbs. Hemiplegia means it is just one side of the body. Double hemiplegia means all four limbs are affected, but it's not involving the cranial nerves, the trunk and the neck. So quadriplegia and double hemiplegia, difference is that in quadriplegia it is just not just the limbs, but the trunk, the neck and the lower cranial nerves are affected. But in double hemiplegia it's just all four limbs, but there is no involvement of the lower cranial nerves or the trunk or the neck muscles. Okay, now what is the etiology of cerebral palsy? 80% of cerebral palsy occurs due to intrauterine brain injury. 10% of the cases, it occurs due to birth injury during the time of birth. And another 10% of the cases, the injury happens during early childhood, like meningitis, any trauma to the brain, etc. So the important point I would like to highlight is that more than 80% of the causes of brain injury is the intrauterine period itself. It's not always the birth or the traumatic delivery that is responsible for cerebral palsy. Okay. Now this is a very important table which describes the motor syndrome, the MRI finding and the causes. Okay, this is very, very important. So, spastic diplegia, that is the most common type of cerebral palsy according to 4 out of 35%. And what is the MRI finding that you see? What you see is something known as PVL or periventricular leukomalacia. And what is the cause of this periventricular leukomalacia and spastic diplegia? It is usually seen in prematurity. Okay, this is a very important table. So premature babies, they can have periventricular leukomalacia on the MRI brain, and that is responsible for spastic diplegia, which is the most common variety of cerebral palsy. The second most common variety of cerebral palsy is spastic quadriplegia, which accounts for 20%, and the MRI finding that you see in that case is multicystic encephalomalacia. And the cause can be either ischemia, infection, metabolic, any causes of injury to the brain during the intrauterine life can cause multicystic encephalomalacia and can cause diffuse brain injury and thus results in spastic quadriplegia. Now, the third variety is hemiplegic CP, which usually occurs due to intrauterine stroke or any cortical malformations confined to one area of the brain. It can usually occur due to thrombophilic disorders or infection. Now, the next important one you have to study is this one, extrapyramidal or ecthetoid CP or dyskinetic CP. Here, what you can see, the injury is in the globus pallidus and the hippocampus. What you call that? It is known as status mammoratus in the basal ganglia. And the most common cause of dyskinetic CP, which causes injury in the basal ganglia and the globus pallidus, known as status mammoratus, is kernicterus. Okay, so kernicterus or bilirubin encephalopathy in the newborn period can result in extrapyramidal CP. Moving on. Next question. So that are the important points about cerebral palsy. The management of cerebral palsy is not that important for an MCQ point of view. So hence I'm not discussing about the management part. Now, a 2-year-old boy presents with difficulty in climbing stairs. So here's a 2-year-old boy. There is difficulty in climbing stairs and noticeable muscle weakness. So there is some involvement in the motor part of the child. Okay. His parents report that he frequently trips and falls, and they have observed that this is the key point. What they have observed, that their calf muscles appear unusually large. So what is the most appropriate investigation to confirm a suspected diagnosis based on the clinical features? So here you have a 2-year-old child with calf muscle hypertrophy and motor weakness, and the main weakness is in the proximal weakness. So you have a motor weakness, which is more of a proximal weakness. Distal weakness, they will complain of slipping of hands from the hands, difficulty in writing, difficulty in combing, difficulty. It's not like that. They have difficulty in walking, difficulty in jumping, difficulty in climbing stairs. All that means it's more of a proximal rather than a distal weakness. So they have a proximal weakness with involvement of the muscle, and there is calf hypertrophy. So what is the diagnosis? And all these are happening in a child who is a boy. So all these features are pointing us towards the diagnosis of Duchenne muscular dystrophy, and the most important investigation that you can do in this child is serum creatinine kinase levels, because it will be very, very high. And elevated CPK in a toddler or a 2-year-old child with difficulty in walking is almost diagnostic of Duchenne muscular dystrophy. So some important points about DMD. This is an X-linked recessive disorder. That is why only males are affected. Females are usually carriers. And which is the gene that is mutated? There is a mutation in the dystrophin gene. And the variant, what is the variant of Duchenne muscular dystrophy? It is Becker muscular dystrophy. Becker muscular dystrophy is a milder variant and is associated with a later onset. Okay. And what are the clinical features? There will be pseudo hypertrophy of the calf muscles. Gower's sign. What is Gower's sign? Because of the proximal muscle weakness, the child has to climb upon himself to stand up from the squatting position. That is Gower's sign. And it is often associated with cardiac malformation, that is dilated cardiomyopathy. And investigations, elevated creatine kinase, and genetic studies always done for the confirmation. And treatment is basically supportive care along with corticosteroids, especially deflazacort, can be used for decreasing the progression of the disease. Okay. So this is a picture showing Gower's sign. See, the child is getting up from the sitting position by using hands to push on legs to stand. The child is pushing himself to standing by supporting weight on the legs. That is climbing upon himself. That is the old saying. Then this is something known as a valley sign, which is again a feature of DMD. What you can see is that there is a infraspinatus and the deltoid muscles, what you can see here, and there are enlarged like two mounts, and in between them the muscles forming in the posterior axillary fold is wasted. So here it forms a valley like thing. So that is valley sign, which is also a feature of Duchenne muscular dystrophy. Okay.